Well, my name is Stephen Sheldon. I became involved in sleep medicine, I believe, in 1980, before anything became formal, because of a patient that I had. I was doing general pediatrics at the time and had just finished a fellowship in medical education. And I had a patient that had a sleep disorder. I was fortunate enough to be at Rush, Presbyterian St. Luke's Medical Center. And one of the most wonderful people that I've ever met, Roz Cartwright, was the head of the sleep center there, which was one of the first clinical and research sleep medicine laboratories in the country. And I asked Roz to help with this patient, and I became totally enamored with two things. One, with Roz and her knowledge and her enthusiasm. And the second was enamored with the absence of information, knowledge, and insight into pediatric sleep. As a practicing pediatrician, I learned about one or two things in sleep during medical school and during my residency program. And most of that related either to behavioral sleep issues or to SIDS, which was the state of the art at that time, and nobody really knew what either one of them was, except the behavioral approach to children's sleep. I was amazed at the absence of literature, and I spent 2 weeks in the library. Now I guess you'd spend 2 weeks or 2 minutes Googling or up-to-dating the information, but it was 2 weeks in the library reading everything I could about sleep disorders in adults. I was absolutely amazed at the lack of information and lack of knowledge that there was about children's sleep and children's sleep disorders. And I had to wing it at the time. There's a little bit about bedwetting, but it had nothing to do with sleep. It more had to do with urology and bladder size and bladder control. And no one knew what SIDS was, so it was an absence of information that was intriguing. And that's what got me interested in sleep medicine. Because I was interested in that, I was able to limit my practice. And all of my colleagues were sending me all of the patients that had sleep problems, and I had absolutely no idea what to do. So I had to use my pediatric knowledge and I guess a whole bunch of common sense in order to try to make an assessment and a plan. Roz helped a lot. The sleep disorders program there was right in its beginning. So I did have that help. And I started learning about sleep from her and from her expertise. I decided after I had a full practice of pediatric sleep medicine, children with problems, that I should probably do it right. And so I did do a fellowship, visiting faculty fellowship at the time at the University of Chicago in sleep medicine. And I was fortunate enough to be there when Alan Rechtschaffen was there, and Jean-Paul Speer was my mentor there, and really learned the formality of sleep and became involved with the organization at that time, was a member of the American Sleep Disorders Association at the time, and the spin-off that Dr. Dement created, the Clinical Sleep Society, which was the clinical component of practice in the ASDA at the time. And I was a member of the Clinical Sleep Society. And I learned by doing. I was amazed because once I think I missed the first 2 or first 3 meetings, sleep meetings, because I wasn't in sleep at that time, and I learned about it. But once I started going to the sleep meetings, I found that there were a few pediatricians that were doing what I was doing. Not many. There were only about a half a dozen that were seeing children with sleep disorders, and we would get together at the meeting of the ASDA at the time, and sit around dinner and talk about our patients and what we thought about the diagnoses and what we thought about management. And we all amazed ourselves at the time that we were basically doing the same things. So that was very comforting. When you don't see someone for a year and you start meeting every year with them, and what you are proposing to do for these various sleep-related disorders, everybody was coming up with the same thing, so there must have been something there. A lot of it was networking. The early meetings of the ASDA was networking. I spent a lot of time in all of the sessions learning things that I really didn't know. The courses were good. The presentations were excellent. And it really helped improve my knowledge of the science, but there was really very little in pediatrics at the time. So what we had to do at that time was take what was created for adults and then try to translate it to the pediatric patient. And the more we did that, the more we found that it was really difficult to do that, because what was true for adults really isn't true for children. The children are not small adults. They're really different organisms with a different anatomy, a different physiology, a different biochemistry. The pharmacology for children is different. The way they metabolize drugs was different. And there was very little research. There was very little evidence to go on. So there was very little evidence-based pediatric sleep medicine at the time. But we hunted for pediatric papers, and we all tried to present what we were doing at the time. And it became more and more important. Then there was a pediatric section that was created, which was wonderful because then more and more we could attract more and more people into the field of pediatric sleep. And it became one of the more favorite and populated, if you will, sessions during the meetings. Leaders in the fields that I had interactions with that influenced me, Dick Ferber was very influential, and a wonderful colleague, Judy Owens, fantastic researcher and colleague, Jody Mindell, and others. I loved Raphael, going and talking with Raphael Paleo early on. And those are the big leaders that I went to and that I studied. Now, Christian Guilleminault did write a book, which I thought was fabulous. I think Dick wrote one of the first books available called Solve Your Child's Sleep Problem, which was both for parents and for practitioners, and it became a Bible of pediatric sleep at the time. And Christian wrote a book called Sleep and Its Disorders in Children, which was one of the first focused books on various pediatric sleep disorders, and they were very, very influencing. Mary Carskaden, leader in the field. No one can say enough about Mary. How I came to write my book. The first book that I wrote, called Pediatric Sleep Medicine, was back in, I believe, 1995. and it was published by W.B. Saunders. And it was interesting because all of those years that I spent in the library researching my patients, just looking for papers that related to my patients that I was taking care of, I had collected them, I kept them. It was different then because we had notebooks filled with photocopied papers. And I looked down at my shelf, and I had them well organized into categories. And I looked, and I had about 24 books filled with hundreds and hundreds and hundreds of articles. I said, gee, it looks like there's a book there. But I started taking notes, and I would take notes just for myself, because I learned by reading and underlining and writing and making my own notes. And when I finished making my own notes, I found that there was enough information there, and W.B. Saunders was interested in the information. I had published a couple of pediatric books before then, Pediatric Differential Diagnosis, Problem-Oriented Approach, Diagnosis and Management of the Hospitalized Child. Those are two of the pediatric books that I had written, and the publishers there actually referred me and with what I had and said, you have a book here, why don't we just publish it? And that's how it came about. When I first got into pediatrics, my first mentor, Joseph Christian, was the chairman of the Department of Pediatrics at Rush. And he told me, and I'll remember this as long as I live, he told me that if you really want to get ahead and learn and influence a profession, you have to get involved with the organizations. And I was originally involved with the American Academy of Pediatrics and the Ambulatory Pediatrics Association, but once I became involved with sleep, the American Sleep Disorders Association and the which became the American Academy of Sleep Medicine, was the thing that I wanted to become involved with. And I always heard Joe's voice in my ear, get involved, get involved. And so I did. I started out as a volunteer in committees. I did a lot of work in continuing medical education, and I had a fellowship in medical education. So I became a member of the Education Committee and the Continuing Medical Education Committee. The CME Committee, I then became chair of when and I can't remember whether it was the ASDA at that time or the AASM at the time, but at some juncture, we went for our first accreditation application so that we could provide CME. And the staff wrote, and the committee wrote the original application to the ACCME for accreditation. And we got it on the first round, and it has been maintained an accredited organization since for providing continuing medical education. From there, as chairing that committee and being on that committee, I think for several years, I was asked if I would like to serve on the board of directors. I was nominated for the board of directors and was elected to the board of directors in 2000. And became involved then, and in 2003 became the secretary-treasurer of the Academy. And it was an exciting time because that was a time of transition where we were going from American Academy of Sleep Medicine accredited fellowships and American Academy of Sleep Medicine accredited people, American Board of Sleep Medicine accredited people, to ACGME application, which I'm really proud to have worked on that application and the curriculum for it. and then continued until 2006. After 2006, I was elected to serve on the American Board of Medical Specialists, the Sleep Medicine Examination Policy and Examination Committee, and I served on that for 4 years. After that, wrote the first exam for the American Board as a representative of the American Board of Pediatrics and the American Academy of Pediatrics. Getting together the application and the process of the transition, I think that was really an exciting time because we were a real small organization at the time. The goal really was to become a specialty and to improve and what we were doing, research and evidence base in sleep medicine. And the route that was important, I believe, was getting ACGME accreditation for the fellowships so that it's internationally recognized rather than just recognized as an organization certifying people. And the American Board of Medical Specialists examination in sleep medicine to certify individuals under ABMS. And I thought that it was quite a time, and it was an exciting time because the AASM was rather small with respect to the other organizations that were involved, the American Thoracic Society and the American College of Chest Physicians, the American Academy of Neurology, and all of these groups had sleep sections, but these are huge, huge, huge groups. And we were small. We had 5,000 members, maybe, not even 5,000 members. And I remember discussing why I thought we would be successful, and afterwards, when we were successful, why we were successful with a number of people. And I looked at what we did, what the American Academy of Sleep Medicine did, and was extremely proud because it did those things that I really believed were important in the practice of medicine and certification. Because the American Academy of Sleep Medicine really focused on three things. It was not a trade organization. It focused on three things. It focused on certification and assurance of the public that people were capable and competent of practicing sleep medicine. It looked at institutions and laboratories with a very vigorous review to make sure that sleep laboratories were capable and competent of providing the services that were required for the general public. And the third was looking at education and fellowship training to make sure that education created those people that were capable and competent of practicing sleep medicine. And those things are the things of which I was most proud, that it was not looking to really make more money for individual practitioners or publicize individual practitioners so that they would go to one group rather than another, but to certify and to guarantee competency and capability of practicing this new specialty, which was really one of the newer specialties around, to the general public. And I think that is what the organization should have done, and was proud to be part of what was done. It accomplished its goal, and I think it continues to do the same. And that's why I came back after I was out of the organizational administration, if you will, being off the board in 2006, and it wasn't until last year that I became involved with the foundation again, and was excited to be elected to the board of directors of the AASM Foundation, which has been a marvelous experience. It's really doing exactly what I believe in, and continue to believe in supporting new research, new investigation, diversity, everything that we really need to do in order to continue the profession on the road upward. When we submitted the application, or when we were writing the application, the one memory that I have that is probably the most important memory was a board meeting in San Antonio, Texas, where we were all given the job. There were 6 sections to the ACGME application, and we split up into groups of three or four people, and we each had a bullet point, one of the 6 sections, and we were instructed that we had to sit down and write that piece of the application until we were done. So we sat there on the river and this was, I guess we had computers then. I don't know how good they were, but I know sitting there with a paper and pencil and notebook and writing out the curriculum that was based on a curriculum that I had submitted to. It was submitted to the American Academy of Sleep Medicine for fellowship program, a fellowship program, a pediatric sleep medicine fellowship program, which we had accredited by the Academy, and took that curriculum, modified it for bullet point, I believe it was bullet point number 6, that my group was responsible for. And we modified that curriculum for submission to ACGME. We came away from that meeting with a completed application. And of course, it needed to be fine-tuned afterwards. Stuart Kwan was involved. I think you were, Larry, you were involved. Mike Silber, and I'm blanking on all the names, so forgive me. Barbara Phillips, Nancy Foldeferry, Mike Silber, I said Mike. Mike Satay was part of the group. And I think Stuart Kwan was the president at the time. And we sat there and we did it. Jerry Barrett was the executive director, and he sat there and he made us write those sections, and it came out excellently. It was submitted, and the ACGME approved it. The ACGME, the ABMS required an ACGME accredited fellowship in order to be eligible to sit for an ABMS sanctioned examination. So the fellowship was created first. The ABMS created the policies in the exam afterwards with requirements, policies for eligibility. And part of that had to do with the institutions and the number of institutions that could have a fellowship, because there were, and the number of specialties that were involved, which was really an interesting process, because it wasn't board certification in pediatric cardiology, for example, or board certification by the American Board of Internal Medicine and Pulmonary Medicine. It was made up of a number of boards. So the Policy and Exam Committee was made up of the American Board of Neurology, the American Board of Internal Medicine, it was Psychiatry and Neurology, Internal Medicine, American Board of Pediatrics, and they all had to come up with similar requirements because the exam was being created by all 5 boards for one exam that all the individuals for all those specialties would take, that would certify them, and they would get certificates from their individual board. So the American Board of Pediatrics gave their own certificate in sleep medicine. The American Board of Psychiatry and Neurology gave their own certificate in sleep medicine. And the same for the other boards. Subsequently, other boards joined in sleep medicine: otolaryngology, head and neck surgery, family medicine, anesthesiology. They all became affiliated with this policy and examination group, and so they could provide certificates in each one of those specialties. But in the beginning, they weren't involved. And I do remember the initial creation of the examination, sitting through the meetings in Philadelphia, writing questions, and we would take the exams over and over again and read the questions, edit the questions. And then they had a very marvelous mechanism, of which I understood little, of how they validated the questions before they were even done. So you would sit down and you would try to figure out the least competent physician, or the least competent person would be able to answer this many questions on this examination. And there was a vote. We would sit around and vote and go through this whole process 3 or 4 times before, and we would go over every single question. And then after the exam was done, we'd go back and see how the questions performed. And it was an exciting process, a very important learning process for me. There were other things that were going on during that period of time. A lot of it had to do with reimbursement, with CMS, adding codes and having to negotiate with the various specialties and with the AMA, their organization, in how the billing codes would be done, how many there would be, what they would be for, and how it related to the international classification of sleep disorders, because there were at the time, I believe, 85 identifiable sleep disorders in the ICSD 1 and 2 and 3. So how that would be distilled down, those were always discussions. One of the biggest discussions that I think is still ongoing is the issue of pediatric sleep medicine. The vast majority of practitioners in sleep medicine are adult focused and not pediatric focused. There are, at the present time, I believe, less than 400 board-certified pediatric sleep medicine specialists, which is not a lot when you look at other specialties. And there's a whole group of disenfranchised people out there, the children, who are really not getting the focus that they really should get. The children are our future, and they are the ones that are going to be growing up and taking care of us. They're going to be the doctors and lawyers and politicians and mechanics and plumbers, and they're going to be taking care of our homes, and they're going to be taking care of our health, and they're going to be taking care of our families. And therefore, they need to be paid, the attention needs to be paid to them in a much more important way. Right now, there is a little bit. It's a lot more than when I first started. So I applaud the organizations for doing that, but it's nowhere near where it should be, nowhere near where it needs to be. And access to care for children and for sleep health services is extremely poor and needs to be expanded. It's interesting because adult sleep medicine specialists who focus on adults, they are licensed to take care of children, but they really don't know how to take care of children because, like I said before, the children are different. So it behooves us to either teach them how or create a situation in which we are going to be able to increase the critical mass of pediatric sleep medicine specialists so that we can provide adequate sleep health to all children, which doesn't exist now. When you look at research dollars, very limited research in pediatric medicines, not only in sleep medicine, but in all areas. And when you look at you look at research studies and review research applications, and I had been associate editor on Journal of Clinical Sleep Medicine for many years, and would review papers over and over and over again. And of course, because I was the pediatric representative, the pediatric papers would be funneled to me, and I'd look at the patient populations and from which the study is being conducted, and their pediatric population started at 15 and ended at 18. I mean, these are adults. I mean, they're not pediatric patients. When I speak about the pediatric patient, I'm talking about the Tanner 1 child who's typically less than 8 years of age. And there are very, very few people that are capable and competent to take care of them unless they were trained in pediatrics. The other group that really has been totally missed and totally ignored is the neonate. And my focus over the years now, and even now, is on the first 1,000 to 1,500 days of life, because those days are most important in development of the human being. Peter Huttenlocher, absolutely marvelous researcher from the University of Chicago, counted synapses, and he did this well before you were able to do it electronically. He did it under a microscope. And he counted synapses and found that in many of his seminal papers that we create the most synapses that we will ever have by the time we are 5 years old. And after 5 years old, the number of synapses that we have in our brains decreases, and it decreases steadily. It decreases by pruning, it decreases by cell death, it decreases across the rest of the lifespan. But from birth until 5, that's a time of rapid growth. And when we look at when we look at cell growth and synapse and neural network creation, they are created and facilitated and strengthened or eliminated by experience, by stimulating the neuron, stimulating it by typically being awake. That's called learning with the development of these neural networks. However, what we fail to realize is that it's stimulated also during REM sleep. that the 2 times that the brain is really active in that way is during wakefulness and during REM sleep. Children who have obstructive sleep disorder breathing, obstructive sleep apnea, desaturate, and they desaturate most during REM sleep. And so what are we doing to their brains when they're growing, when they're 3 months and 4 months and 5 months old, or 2 years and 3 years old? Now, that might not be an issue of major mortality, which I think is the most important driving force in creation of therapeutics, the prevention of major morbidity and mortality. But if you take a 3-year-old and you oxygen deprive them intermittently at night during REM sleep, and they grow up with less neural networks than they would have created otherwise, are we dooming them to a lifetime of not being able to read well, or not being able to add or subtract or multiply and divide well? We don't know. And these studies are really lacking. And we do know, though, that when speaking of obstructive sleep apnea, if you don't do an adenotonsillectomy on a child that has mild to moderate obstructive sleep apnea, or you do an early adenotonsillectomy, at the end of a year, they'll end up with the same apnea plus hypopnea index, AHI. So are they any different? Yes, they still are, because maybe the AHI is not the right metric at which we are looking, because these children that didn't get an adenotonsillectomy, when you look at them, their neurocognitive testing is worse than those children that had an early adenotonsillectomy for obstructive sleep apnea. So is the morbidity that we're looking at not major for a general population, but it is major in a couple ways. One, it's major disability for the child. And two, they are going to be adding to healthcare costs when they grow older. For those children who either require special education, require more resources in learning how to read, or can't read at that point. So those long-term outcomes may be major, both societal and for the individual patient. So information, a lot of that information we don't know yet, and I think that it behooves this organization and other organizations to focus on these issues and put as much emphasis on these issues as placed on any other issue that relates to sleep medicine. And it's a tough road. And I'll say something that's really probably going to be quite controversial, but children are pretty much ignored for 2 major reasons. One, they don't vote, and 2, they don't pay taxes. And so are they contributing to our society? They sure are, because they're developing into those people that will be voting and that will be paying taxes later. They're just not doing it now. So we really need to understand that they are going to grow up to be taxpayers, and they're going to grow up to be voters in the future. And so we need to pay attention now with that in mind. I really believe the most important thing is for those that are in the field to become involved. And to become involved in the organization and volunteer for committees, volunteer for those things that they can do, because it is a great learning experience. I think the Academy really needs to focus, and it is, I'm not saying that it's not, but it needs to focus on increasing the critical mass of practitioners, paying attention to those practitioners so that they can bring in new practitioners with new insights, and bring in new investigations and focus on younger and younger and younger children and put an emphasis on that, perhaps, and I might get into trouble for saying this, create an organization within the academy, or have the academy support an organization that's a pediatric organization. And I say that because, and I have written a number of times about the development of pediatric sleep medicine, and it seems to be following the exact same pathway as the development of pediatrics as a specialty, because back in the late 1800s, there were no pediatricians, there were no pediatric hospitals, there were no pediatric wards, and children were being taken care of at home, and the only treatments were fluid and sunlight. The pediatrics started by a group of internal medicine specialists and family practice specialists who devoted their practices entirely to children. There were about a half a dozen of them. They had 3 or 4 beds in the corner of a hospital. Well, that's how we started in pediatric sleep medicine. My first sleep laboratory was in a closet. I had a closet, and we put a mirror there and 1 bed. And we graduated to 2 beds with a separate tech room. And we monitored with a video camera and made videotapes and recorded everything on paper and had a warehouse-sized room. So I think that we need to continue to go down that road, and the academy needs to look at children in a much more important light. Not that it's not looking at it at all, because it's much better and much more advanced than when I first started. But it needs to continue as it's going and growing. I think that slope of growth needs to increase. The AASM is the most important organization for sleep medicine specialists because it focuses on those 3 things: the competency of people, the competency of laboratories and centers, and the competency and excellence of education.